tumors.
So we'll get into the challenge with the way that clinical trials are done today, because the question always from the people that are in the medical field are always like, well, where's the evidence? Where's the evidence? And usually they're talking about these randomized, placebo-controlled trials. We're going to get to that in a second. But first, let's talk about at least your studies of what you've shown in mice. And then also, I do believe that you've collected case studies that are out there. Do you have case studies in, I've seen the ones that are there in animals. Do you also have case studies in humans showing that when you starve the cancer and then also use these low dose concentrations of drugs to kill the cancer, that people can ultimately radically slow down or even, kill off the cancer that they're dealing with?
Yeah, yeah. This is the strategy, to slow the whole tumor down and degrade it very slowly. So,
and have you and your team collected case studies together of
yeah,
different groups that are out there? It's still emerging, and obviously that's one of the
yeah,
big problems with this is that it's not like MD Anderson or here in UCLA in Los Angeles is practicing this new approach. This is sort of a whole new approach to cancer in itself. But what documentation do we have at least right now before we get into clinical
okay,
trials?
okay. We base it on two things. Before you have to have a logical mechanism of action for doing something. In other words, there has to be a scientific basis for why you would do a trial in the first place. Okay, why you would treat a human, a mouse, a dog, or whatever. It has to be what do you just grab something off the shelf and chug it down? Maybe that solution over there might work. No, there's no mechanism. We in Warburg and others have clearly defined what the underlying process of the tumor cell is, right? We know that from the preclinical studies, from the cell culture studies. We know that. We know what's driving the cell. So now take a human being that has a tumor, and you say, we're going to now, based on our understanding of the scientific mechanisms that are responsible for your dysregulated cell growth, we will now institute a therapeutic approach designed to target that process. And when we do that, we get really good results. The problem is you cannot take 50 people and do this because you need to know each person. You have to know that person's metabolism. You have to know that person's sex, age. You have to know what other conditions in that individual are there that need to be addressed before you can start doing this stuff. Before you can start treating a patient with ketogenic metabolic therapy, does that person have parasites? Does that person have type 2 diabetes, hypertension? There's a whole variety of things that have to be evaluated up front before you can then elicit a therapeutic strategy for managing that person's situation. So you need to do a very comprehensive blood work on that individual. So you can take 20 individuals and all 20 may have a different profile of blood markers and things. So you might have to ease one person in a little bit differently than another person. You need to try to manage as best you can, bring that person into a new metabolic state. Then once that person is in a metabolic state, then you can look at non-invasive strategies for managing his tumor. What is that? CAT scan, PET scan. These kinds of non-invasive ways to determine whether or not the individual's tumor is showing some level of response to the treatment that you're using. Then once you have that, the tumor becomes somewhat stabilized. Then you can then introduce very low doses of certain drugs that are known to act synergistically with the diet or with the new metabolic homeostatic state. Drugs that will target the glycolysis, the glucose utilizing pathway. Drugs that target the glutamine utilizing pathway. And they would be delivered in pulses, and they would not be delivered in great excess amounts because they're working synergistically. How do you ask the guy, how are you feeling today? I feel great. What are you guys doing? So I said, well, that's good. That's a good first step. So we can't, people go, where's the evidence? What are you going to do? Take 100 people and just, throw something at them that you have no clue. You don't understand the biology. You don't understand. You got to, we work with small numbers of people, individual case reports, and then we publish those case reports. And then we look at what worked for this person, what worked for that person. And then we can start to get some sort of a strategy together. So the answer to why are there no major clinical trials? There are. Most of them are not done correctly because the people doing them don't have an understanding of the biochemistry that's underlying this. So I don't fault them because a lot of people themselves would like to be treated with metabolic therapy. The problem is that the practitioners, the physicians, don't always have the necessary background or understanding of what they are supposed to do, how to do it, and how to measure outcomes. We're in the process right now of writing a very comprehensive treatment protocol for managing glioblastoma, which is one of the most deadly and unmanageable cancers that we know about today. We have a very comprehensive strategy for managing this kind of a tumor. Can it be done? That's another thing. Oh, we have this tremendous treatment protocol for glioblastoma, but nobody will use it. And the answer is, how could that be? Because we have the science behind it. We know from preclinical research, from our preclinical research, that it will be very effective. We have individuals, case reports, knowing that it will be effective. Why can't it be used in like the major oncology centers? Because they need to have the standard of care done first. And I told them, I says, so we have you have to have the groups of people. Okay, we have one group of people get the standard of care. 90% of them are dead before 5 years, more. Okay, then we have metabolic therapy used with the standard of care. Okay, so we're starting to see these folks doing a little bit better than standard of care by itself. Well, where is metabolic therapy by itself without radiation and chemo? Can't do that. No, not allowed. Not allowed to be done at any of the major medical centers. The board, the IRB, Institutional Review Board, has nixed those kinds of studies.
Because they would say that you're harming the patient because you're not following what we've established to be the standard of care, which comes from the fact that, hey, cancer is a genetic disease, not a metabolic condition. Right, not metabolically driven.
Well, it comes from the ideology, not only that cancer is a metabolic disease, but their complete lack of understanding of what their actual standard of care treatments are actually doing to contribute to the rapid growth of the tumor in the brain. So, as I have published very clearly over and over again, when you irradiate somebody's brain with a tumor in it, you explode the amount of glutamine in that microenvironment, giving those tumor cells an absolute a bouquet of growth factors and fuels to grow out of control. So you create a mush in the brain. You give the patient high-dose steroids to control the swelling of the brain from the radiation heat. Steroids are like drinking Coca-Cola. They make your blood sugar go up to very high levels. So what are you doing? The very treatment that you're throwing at these poor folks is contributing to the recurrence and the death of the patients. And I've said that over and over again. Why there's so little survival for glioblastoma? In every major medical center in the world, it's so consistent that people are all dead before 40 months. Not all. You get very rare survivors occasionally. Almost everybody in 10 years is dead for sure. What are you doing? I said that's the worst thing you can possibly do to somebody with a brain tumor is irradiate them. And yet they continue to do it. And one has to say to these guys, what's wrong with you? What do you ignore the scientific evidence? What are you doing to these poor folks? I've clearly shown that that's what's creating the recurrence of the tumor and killing the patients. Why? Because it frees up massive amounts of the two fermentable fuels needed that's the science behind it. You got to understand the science behind what's going on. And it makes perfect sense why these folks are not surviving. They look like they're doing well for a while, and then all of a sudden that tumor comes back like a raging bull, and the liquefaction of the brain from the radiation, it's just like, it's tragic. It's malpractice as far as I'm concerned. to do something like that. It'd be one thing if there wasn't any evidence. It'd be one thing to say, well, this is the best we can do. But when I publish evidence and I clearly show that that treatment is responsible for the demise of the majority of these brain cancer patients, it's criminal to be doing something like this. I'm telling you, man, this is like nuts. And, people are saying that, it's hard to reproduce science. There's nothing, you should see how reproducible the death of the cancer patient is. You can't design better experiments for reproducibility than how fast standard of care kills GBM patients. That's terrible. Isn't that terrible to say something like that?
It's terrible.
Well, why don't the patient go look at the data in the literature? It's not coming from my mouth. It's coming from the data from the top medical schools.
Yeah. I mean, the audience, everybody listening here, they can feel your passion for what.
Well, when you see enough of this crazy shit for as long as I have, you say to yourself, "What am I going? Maybe I'm going nuts."
No. It's basically you're being, your work and research is being, the phrase is overused, but it's being gaslit by the medical profession. Many of them, again, under that sort of, this is the consensus. It's already been established. You can't question it. Until, unfortunately, we're in a situation where...
Jethro, why don't you get one of these guys from the top medical school and ask them, why the hell you radiate your patients? Don't you know it's killing them all? Go ask them that. See what kind of response you get.
Yeah,
you probably won't even want to come on your show.
They wouldn't want to come on, for sure.
Well, you got to ask them these questions, because I'm certainly asking them.
No, we do. It's important. And I think, like you said earlier, the groundswell is coming from the lay people who are interested in hearing directly from sources like yourself. This is why, podcasts around the world have really taken off, because people want to hear the full story and they want to get a chance to decide if they want to investigate something, and they want to weigh the pros and cons of looking at stuff.
Here's the problem. I can say all this stuff because I have done the basic research myself. I have looked into the concepts. I have studied these concepts. The problem and the great tragedy is when the cancer patient with a glioblastoma, lung cancer, breast cancer, whatever it is, they go to the top medical schools and they tell them, I want metabolic therapy. And they, we can't do that here because there's no evidence that it works. So these poor folks are now, hear what I say. They get all fired up. They go down to the top medical school to say, I want metabolic therapy. Well, we don't do that here. Well, who does? Oh, I'm going to lose my license if I do that. What the hell is going on with that stuff? So I feel bad when they say, whoa, where's Seyfried's clinic? I don't have a clinic. I'm not an MD. I don't treat patients. Why are there no clinics? Well, because a lot of the folks that would need to be doing this could lose their license if they treat patients without the standard of care. So why is the standard of care written in granite? Why can't it be modified in some way where the medical schools, they should be the ones? Dana-Farber, MD Anderson, Sloan Kettering, the Moffitt, the Fred Hutch, all of these major cancer centers throughout the country should be the ones that are doing this. Why are they not doing it? That's the question.
Yeah. What's that famous Max Planck quote from the German Nobel Prize winner, the theoretical physicist? I'll paraphrase here, but advances in science, and you could extrapolate to medicine too. Advances in science happen one funeral at a time, because it's very hard to get the old guard interested in doing things that has them completely re-question their core and basic understanding.
Well, yeah, but then we have to get rid of those. Well, okay, well, that's good in concept, but we're allowing people to die. I mean, it's not like this is an insignificant thing.
It's a very tragic thing.
We have almost 1,700 people a day dying from cancer, right? And we have to wait for these guys that can't understand the basic concepts to die off before we allow these poor folks that could be alive, that could be doing better, for a bunch of people that are standing in the way because they either don't want to know about this or they can't understand it. I mean, this is tragedy. So what are you going to do? There has to come from the people themselves. They're the ones that are going to be affected by this. So they have to demand. People themselves have to demand. They want metabolic therapy, for crying out loud. And if they don't do it, somebody else has to do it. Put pressure on the congressmen. Put pressure on the senators. And then President Biden himself says, we want to bring cancer deaths. We could do that in 5 years, not 25 years. It's just that I don't know unfortunately, he's not any different from the rest of the folks. They just can't understand the metabolic therapy, that the understanding the science behind it. And they keep gravitating towards moonshot stuff and CAR T immunotherapy. And all that stuff is based on the somatic mutation theory of cancer. If the somatic mutation theory of cancer is not correct, what is the probability of reducing the death rate from cancer? It's not going to happen. So you got to realize, man, it's a totally different kind of disease and needs a completely different strategy.